Hi, and welcome to the final presentation of October. This one today is going to be a little bit different. You can see the slide right here says the topic is going to be exercise and reducing pain. Now, this may not necessarily be what you think. This presentation is going to be targeted heavily towards individuals who are thinking about utilizing exercise, both aerobic and anaerobic training, as a way to manage pain in their clients. There's also going to be a couple tips on how to properly use whether or not to use painkillers during training, et cetera, et cetera. So we're going to get into all that as we go along. So without further ado, here we go. Now, what is pain? Now, bearing in mind as pain science is, of course, still evolving and, still progressing, there are going to be a lot of different opinions and a lot of different definitions, some of which come and go. But what we do know is that pain is complex. Now, pain, as we know, is not simply damage. You don't actually have to have any sort of structural physical damage to experience pain. Nor do you have pain every time you have structural or physical damage. Technically, it is all in your head. It is your brain essentially processing inputs. So the definition of pain is an unpleasant sensory and emotional experience associated with or resembling that associated with actual pain or tissue damage. Now, notice the sensory and emotional experience. That is absolutely crucial to this discussion, and we'll touch on it more later. So, of the sensory component, we have two types. The nociceptive type, which is essentially those sensory nerve fibers. Those are nerves and other structures that actually process what are typically three kinds of stimuli. That is thermal, hot or cold; mechanical, which is stress, cuts, etc., or chemical, which is the presence of certain compounds that directly stimulate pain. If you've ever been stung by a bee, for example. Now, this nociceptive pain can be divided into several different types. There is visceral pain, which is usually associated within the body. Your heart, your stomach, your liver. Most folks have experienced this at various points. The nociceptive pain in the visceral area is usually associated with stretching and inflammation. Many folks may know that it's more often than not. It's kind of this dull pain that's associated with nausea, just generalized discomfort, the kind you can't get away with. This is not a very pleasant sort of pain, but very different than the next two. Deep somatic pain, which is typically described as dull and aching, sort of poorly pinpointed. Crushing and swelling is usually what causes this type of pain primarily. You can think of this as the pain that you might find in your joints, for example, or in your lower back. This is pain where you can, if you had to put your finger on where it is, you could be missing the mark entirely, but you generally know what region it's coming from. It's not as specific. Superficial somatic is usually what you associate with, cuts, scrapes, bruises, etc. Superficial bruises, really. Sharp and well-defined, you can usually point exactly to where that pain is coming from. That's what most of us are familiar with injury. Now, there are two other types of pain here, or nociceptive pain. There's nociplastic, which is a general change in a sense of pain or sensitivity. Now, remember, nociception, these sensory nerve fibers, they have a certain threshold at which they activate. And, when you touch an object, you obviously feel it. Picture yourself, if you're sitting in your chair or anywhere else listening to this right now, think about what you're feeling right now on your butt. And could it be described as discomfort? Even if you're in a relatively comfortable chair, it's interesting if you focus on that spot where your butt actually touches the chair, it's actually objectively somewhat uncomfortable. But you don't interpret it in terms of pain. Now, nociplastic pain, which is something that's typically associated with, say, fibromyalgia, etc., would be a change in the sense of pain or sensitivity. So, in other words, what would normally just be, just a sensation of touch or even something slightly itchy or ticklish, etc., would be then processed as actual pain. And the last is neuropathic pain. Neuropathic pain is usually pain that involves, it's specific to the nervous system itself. It could be actual, damage to the fibers or, change in chemical stimulus to the fibers itself. When you just talk about, any kind of neuralgia, pinched nerve, that kind of stuff. Anyway, so that's that. Now, the other kind of pain is psychogenic. Usually people think of it as psychosomatic. Now, psychosomatic, yes, like we said, all pain is in your head, but psychosomatic is typically not specifically triggered by those sensory fibers. It's pain that is either initiated by or potentiated or prolonged by the brain. Now, of course, this is pain that you still very much feel. The brain is still processing it as pain. It just doesn't have a clear sensory input that's causing it. There are also two types of pain. Now, this is, kind of subject for debate. There are all kinds of changes in nomenclature and everything else, but I'm going to refer to it as these two, the lateral and medial types of pain, so named for regions of the thalamus. As you can see, the lateral regions, typically associated with being able to identify the location or intensity, etc., the sensory aspect of pain. The medial regions, are typically more scattered medial regions of the thalamus, are associated with the emotional response to pain. And again, this is critical. An example of this. Now, say you walk up, you take a pin or a cactus needle or something else, and you push on it with your finger, and you want to see how hard you can push on it. You're feeling the pain. When you're doing that, you're feeling discomfort. You can even do this with a pen. Now, think about the fact that you're in control of this feeling. You're processing it as pain. It's certainly uncomfortable, but it's not shocking. It's not getting to the point where this is causing you much distress, usually, if you're self-inflicting it. Now, consider suddenly having that feeling happening to you, like, say, in your lower back just as you're running along. You might assume you got stung by a wasp or something else terrible happened to you, and it would probably cause quite a bit of fear. Even though the exact same lateral input, the exact same sensory input in both those stimuli, the medial response, that emotional response to one, is far greater than the other. That is critical for understanding. Why is that? Well, when you talk about managing pain and managing discomfort, there are ways to manage both kinds of pain, but most, like, say, anti-inflammatories and painkillers only manage that lateral aspect of pain. In other words, all they do is sort of dull the initial sensation. They don't necessarily change how you react to it. Your kind of psychological and overall, again, that medial response. That is absolutely critical when it comes to pain management, especially for those dealing with chronic pain, because that medial aspect of pain and that medial response to pain, that emotional response to pain, is one of the most crippling and debilitating types of it. Anybody who's ever had chronic lower back pain may know that, if you're dealing with lower back pain and you want to get out there lifting again or anything else, even the slightest negative stimulus, if you're, say, lifting weights, is suddenly, it's almost paralyzing. You've ever injured a knee or anything else, any sort of sensory input, whether it's, the somatic sensory input or anything else that you're going to feel is almost panic inducing. Now, of all the drugs that manage pain, it's mostly opioids and THC that aid in managing both. They actually help you manage the medial aspect of pain, the emotional response. Now, as we know, they're very, very effective painkillers, both of them. In some cases, including THC, CBD, have anti-inflammatory properties, etc. But that is one of the reasons why these are so frequently prescribed and also so frequently overused in management of chronic pain. What we want to talk about is how we can use exercise to help deal with the medial component of pain. So, now, what is the utility of pain in sport? First, let's get to a couple more definitions here. There is pain tolerance versus pain threshold. Tolerance is how long pain at a given level of intensity can be tolerated. There's supposed to be a D there. Threshold is the level of noxious stimulus required to elicit a pain response. In other words, let's say you're feeling something that you rate as an 8 out of 10 pain objectively. How long can you deal with that 8 out of 10 pain before you decide you've just had enough? That is your tolerance. Threshold is the point at which you say, okay, that's fine, that's fine, that's fine. Ow, that hurts. That's threshold. Now, pain is very, very useful for athletes. It is, as you see here, useful as a throttle control regulatory system. Cyclists, for example. Cyclists very much, and again, most endurance athletes rely on this pain feedback, this pain perception to know how fast they're going as throttle control. If you give certain compounds to athletes, let's see, like tramadol and other painkillers, and even large amounts of ibuprofen, for example, you may see a short-term performance increase. They may perform the first part of a time trial much faster, but their pacing ability is so damaged by the use of these painkillers that they may find their overall time trial performance decreases overall. Certainly when it gets to a point where they start tapping into lactate threshold, etc. What's interesting is as the time trial goes on, their ability to regulate their output gets progressively worse while in the presence of painkillers. RPE. Typically, RPE, rate of perceived exertion, is very much dependent on numerous different pain and discomfort inputs. Nociceptive feedback in many cases to manage intensity. You think about it. When you unrack a squat, you feel the weight on your back, you feel the stress and strain in your joints, tendons, your stomach pushing against the belt. There are a lot of different things to let you know you're properly positioned, and when you're truly pushing a limit, it's not just strictly comfortable muscular failure. So, now, multiple studies show that endurance training can increase pain tolerance. People often think, well, maybe some of these crazy ultramarathoners are just born that way. Often they're not. Many studies have shown that perfectly normal individuals off the street, when enroll in endurance training programs, dramatically increase their pain tolerance across their board. That is very noteworthy because effectively, yes, sure, some of us are just naturally tougher than others, quote unquote, but very often it's the type of training that they do that specifically lets them tolerate more pain. Why is that? It's certainly not that they feel anything less. Athletes often are very good at managing the medial aspect of pain, which, if you think about it, the emotional response to pain would decrease the more you self inflict it. So, two things we're going to talk about: associative versus dissociative. If people are familiar with associative pain management techniques, picture yourself, getting on the airdyne or running up a hill or doing anything else and pushing really hard and everything starts hurting. Associative is really feeling the pain and saying, okay, this is making me better. I'm breathing hard. I'm feeling the burn. This is the sign I'm pushing. I can handle it. Really embracing that pain and discomfort and saying, okay, I'm in control of this. I am its master. It's not going to beat me, etc., etc. All of that where you acknowledge the pain and you don't try to get yourself out of it, that is known as an associative technique. Dissociative pain management techniques would be something like, say you're running on a trail or mountain biking and going up a hill and you're thinking, okay, when this is over, I'm going to go get a bacon cheeseburger. I'm going to go get McDonald's or donuts or whatever. Or, looking around, looking at the trail, looking at the view, just appreciating it, oh God, the air smells good. Am I going to be here next year? Anything that it can have anything to do with the activity itself, but is not specifically focused on the effort. In fact, you're trying to focus on things that are precisely not causing you discomfort. Interesting sidebar here. Men tend to have more associative, more often use associative techniques, and women more often use dissociative techniques. Which is better? Well, it really depends. In both cases, you see performance increases, but what's interesting is if you look at enough studies, you'll start to see a trend emerging that associative techniques seem to be marginally superior for shorter duration, high-intensity activity, where dissociative tends to be marginally superior as duration increases, which in a way makes sense. One is more a case of let's push through this, and the other is more a case of, hey, let's just pace and be along for the ride. It's worth noting at this point that there are no sex differences in pain tolerance, really, despite what people may think to the contrary. But there are certainly differences here which may, in fact, explain why more women find themselves better suited for longer duration events than men. And you actually, even though peak performances at super long distances and ultra endurances events are still, there's still very much a gender gap, there is proportionately more, and we're seeing more and more women showing up in higher amounts and higher numbers and doing quite well. It's entirely possible that a portion of this is just in how well women seem to manage pain, including the use of dissociative techniques as time goes on. Now, interesting to note, pain threshold is absolutely unchanged. None of these change your threshold, they just change your tolerance. How about lifting? Well, there's significantly less profound effect on pain tolerance. In fact, the next sentence says that strength athletes, obligate exclusive strength athletes, have pain tolerances equal to regular population. I've even seen studies that show they have a slightly lower pain tolerance than the regular population. So, strength athletes who, talk very much about how tough they are. Sorry, guys, that doesn't work that way. But there is some evidence that the threshold is marginally increased. Part of that could be very much because of repeated tolerance and repeated pressure-induced pain. You may, in fact, as a strength athlete, have a slightly increased threshold for visceral or deep somatic pain, which might very well be why so many, and this is strictly me theorizing, but something along these lines, why so many strength athletes are very good at ignoring both orthopedic issues and things like, hernias and heart attacks and things like that. Not really processing many of those inputs, those chronic inputs, as pain anymore, may in fact be a result of the training. So something interesting to think about. Strength athletes also have, or strength training also improves depression scores and overall pain points, reduces the number of pain points and fibromyalgia. So again, this could be very well due to management and continuous exposure to occlusion and pressure, and as well, possibly some associative pain management techniques for joint connective tissue stretch, etc. So, in many cases, this is similar to endurance training in that you are self-inflicting a manageable, non-threatening discomfort repeatedly. So why would this help? Well, it is this understanding that you can tolerate greater discomfort. Discomfort does not mean harm, pain does not mean damage, and being able to break that link may be absolutely crucial in pain management. Do not fear the experience of pain. Well, and again, why is this important? Because reducing the medial aspect of pain, this is a major goal of pain management so far. We have so many compounds that reduce the lateral component of pain. Any number of over-the-counter drugs. You can go up and down the list of various, topical painkillers and oral painkillers, etc. But none of them seem to have much impact on the medial aspect of pain. But it seems like proper utilization of exercise and incorporation of exercise, particularly aerobic training, can really help in managing that medial side of things. Now, how can I use this? If you are a coach, an athlete, you say, well, here's another reason to lift and run for sure. This is certainly an interesting point to keep in mind if you want to start learning about pain management and looking up associative and dissociative techniques. It also points out that your existing athletes may benefit from more crossover training. Certainly being able to increase your pain threshold, increase your pain tolerance, even I mix them up, is very, very useful for athletes in both strength and endurance sports and even team sports. So you can even say, hey, here's another reason to get a lot of your, rugby players or anything else doing a little bit more cardiovascular training and steady cardiovascular training, is it's going to increase that tolerance significantly. Now, last bit, should athletes use painkillers in general? I am very much against the use of painkillers in athletes. First of all, it can decrease your overall endurance performance. If you're training, especially with them, you are altering critical feedback that is absolutely necessary for knowing where on your limits you are operating, especially if you're one of those individuals who kind of eschews the use of a watch, doesn't like using them that much, or doesn't go by heart rate and would rather go by feel. If you're using any kind of painkiller, you're effectively ruining your ability to understand feel. And also, again, here, if you look at the next one, increased risk of orthopedic injury, hernia strain, resistance training, because you are reducing that compression, pressure, visceral feedback that is so critical for understanding when you are actually going to be suffering some sort of damage. Now, typically, the pain and pressure that you feel, especially under heavy weights, a lot of that is critical, and you will notice a sudden change, of course, when you start approaching your threshold for actual physical damage. Anything that is reducing that, lateral, that sensory, somatic, nociceptive inputs is going to really, really hurt your ability to manage that. Now, you may use these if injury or pain that you're dealing with is otherwise being actively managed. For example, coming back from rehab, you're doing physical therapy, which is uncomfortable. Otherwise, you can use small amounts of it. But it is far, far better to use associative or dissociative pain management techniques to actually be able to start to manage discomfort during training and, of course, identify the cause of actually any issue. So that is my view on that. Use of opioids, including kratom. I did a whole special on kratom. Please don't use kratom. Even though people laud this compound, it is almost biologically, in terms of its effect, no different than certain opioids out there. People just like it because it's easy to access. They say it's not addictive, except metrogenine absolutely is. Basically, people who use kratom are honestly just excusing the use of a opioid that is legal to find for the time being. But anyway, use of opioids, THC, and others during exercise may reduce or eliminate all those positive pain management adaptations. In other words, every sort of mental, emotional, actual technique you are using to manage discomfort, that is one of the benefits of this exercise, may be reduced or even eliminated if you are using an external compound that actually manages pain for you. So there you go. Hopefully this was interesting to some folks. Certainly something I've talked about in the past. It is continuously evolving with time. I'm sure there's plenty of disagreement and debate around this entire topic, but again, hopefully this is of some use, especially when it comes to maybe getting some of your older clients or injured clients to do a little bit more training. Cheers.